Welcome, everyone, and thank you for joining us today for the latest session in the Donald Maloney, MD, Dialysis Leadership Medical Director webinar series. I'm Kelly Brooks, coordinator for the Forum of ESRD Networks, and I have a few housekeeping items to go over before we begin. First, please remain muted to minimize background noise and interruptions. You will have an opportunity to submit questions using the chat feature. You may submit questions at any time during the presentation, and we will answer them at the end of the webinar. Lastly, today's webinar is being recorded and will be posted to the forum website along with Dr. Landry's slides for future reference. A survey link to an evaluation form will be included in the chat and in a follow-up email you will receive after the webinar. We would very much appreciate your feedback. So let's get started. I'd like to introduce Dr. Preethi Yaram, Chair of the Forum's Medical Advisory Council, who has some introductory remarks.
All right, good morning and good afternoon, wherever you are. I have the privilege of introducing our speaker today, as well as the Donald Maloney Dialysis Leadership Medical Director Series. For those that have joined us before, you've seen probably how well received these were, and thank you all for joining. We really appreciate you joining us for these webinars. And these are all available on our website. So we have gone through a major chunk of these webinars already. This is the last but one series. And the next one is going to be how to effectively round in the dialysis unit. And Deborah Hain is going to be giving that, and that's going to be the last one that will be in June. So this series was named after Dr. Don Maloney, who I see is on the call. So hi, Don. And this is to recognize the immense work and contributions he's made to the forum over the years, and he continues to do so. So we are very thankful for his contributions as well as leadership, and hence, this series has been named in his honor. So I hope you are able to join our last one as well, and also spread the word, share this, resource with your colleagues and friends, and direct them to our website. And Kelly is gonna put the link in the website as well if you want to just click on it, and you can go to that directly. Next slide. With that, I have the privilege of introducing our speaker today, Dr. Daniel Landry. He's an associate professor of clinical medicine at UMass Chan Medical School, Bay State. He also serves as the chief of the Division of Nephrology and program director for the Nephrology Fellowship at Bay State Medical Center in Springfield, Massachusetts. He's the president of the forum and the chair of the ESRD Network on Medical Review Board. I have the privilege of working with him quite a bit, and he's been a great leader. He's been leading the forum into new, territories and horizons. So I'm very thankful to be able to work with him and call him a friend. Welcome, Dan. Take it away.
Thank you, Preethi. Thanks, Cal. All right, let me pull my slides up. It's a real honor to be able to speak in front of everyone here today. And here we go. Do we have the full slide set up? Is it okay? Here we go.
Looks good, yes.
Okay, terrific. Well, great. Thanks everyone for being here today. And as Kelly and Preethi both mentioned, our next to last talk for this series, one that we're going to obviously keep available to everybody on our website, and we hope to do more of these types of projects going forward. I think it's been quite successful, and we've really had a great time doing it. So today we're going to talk about optimizing kidney care, and specifically addressing home dialysis and value-based care models, and how this all kind of ties together in 2026. The goals for today's talk will be a brief discussion about the history of home dialysis in the United States, which I find really fascinating. It's one that I give a more detailed talk to our fellows every year so they can really understand the history of where we come from and where we're going. We're also going to have a description of the Advancing American Kidney Health Initiative of 2019 and how that led to more value-based care models and more of a focus on home dialysis. Then we'll discuss some challenges associated with home dialysis uptake and education and other factors, things that we need to really kind of continue to work on and improve upon. And I will share some personal experiences from my own group because I have been actively involved in value-based care now for better part of the last decade. I will share with everyone first and foremost that I have no conflicts of interest of anything that tie in today's talk. I just mentioned that, as you mentioned, I am the president and in a voluntary and unpaid role for the National Forum of ESRD Networks. And we're a not-for-profit organization. We advocate on behalf of the 18 federally mandated ESRD networks throughout the country and in its territories. And our mission is to facilitate the flow of information and advance the national quality agenda with CMS, who we meet with regularly, and other members of the nephrology community. So this is just a little map of, for anyone here who's not aware, so you can kind of pinpoint and identify where your local, where your network is for better reference moving forward. So with all that said, as I promised, let's just kind of start with a bit of a history, and a brief one at that, as I mentioned, one that doesn't give true justice to everything that's gone on. But I think if we're going to look at home dialysis here in the United States, the time frame really is in the mid-1960s. And just as all those things are picking up, it came off of a speech that was given by a vascular surgeon of all people, Charles Kirby, at the American Society of Artificial Internal Organs. This at the time was one of the largest and preludes to nephrology-related groups to speak at national conferences. And he said, perhaps what we need is a home dialysis unit to be placed by the patient's bedside so that he can plug himself in for an 8-hour period once or twice a week. And by early 1964, out here in Boston, Dr. Merrill and his group are beginning to use twin coil dialyzers at home, dialyzing 4 patients specifically, about 5 hours twice a week by their spouses. And a physician and nurse would come by every so often to check in on them. So you can see where, this idea after the early underpinnings of hemodialysis just getting started in this country, where all of a sudden people realized, from a practical nature, for a cost effectiveness nature, as I'll share with you, home is probably the place where a lot of people, not all, but many people would like to be, and one that can be of benefit to many. And another person who doesn't get a lot of notoriety, from at least my opinion, in the nephrology landscape is a Dr. Babb, Albert Leslie Babb. He was eventually actually nominated for a Nobel Prize based upon his work, but he was a chemical engineer. He headed the nuclear engineering department at the University of Washington, and he actually had a close family friend whose daughter was dying of kidney failure related to lupus. And he was approached by that friend and said, is there anything you could do to help me so we could try to provide my daughter dialysis at home? And Dr. Babb, working alongside Dr. Scribner, a name I think probably most people here recognize quite well in terms of creating the first really usable AV fistula or shunt, if you will, worked together and created the Mini One, a machine that Caroline Helm used at home for a period of time until she ultimately did pass from complications related to kidney failure. But nevertheless, these are the first beginnings of dialysis provisions for people in the home arena. And as it kind of started to take off in that Seattle area, patients typically were dialyzing every 5 to 7 days when symptoms developed. And it soon actually over time changed to about 12 to 20 hours at a time, twice weekly, as they started to recognize that patients who dialyzed less were developing severe hypertension, as well as probably the effects of buildup of amyloid plaques and other things leading to peripheral neuropathy. And while they did twice weekly dialysis for longer hours, remember these were days when we didn't really have the data yet on KT over V and other things that in terms of understanding how to best manage many of these patients. It did later change to 3 times a week for convenience, just given the lengthy duration of the treatments. And before long, and actually really almost simultaneously, in London, a Dr. Sheldon is actually beginning to do the first beginnings of nocturnal hemodialysis, where he would dialyze patients 3 nights a week overnight in their homes for 6 to 8 hours at a time, and proved to be very effective. So as physicians start to get comfortable with this, and we're seeing things pick up in Boston, in Seattle, in London, the University of Washington, which really was a true leader in all this, they instituted a remote program. So they said, let's see if we can try to actually offer oversight and support and training to patients outside of the Seattle area, and started doing so not only in the United States, but actually in some other countries outside the United States as well. In 1966, the Seattle Artificial Kidney Center, which was the first large external dialysis unit created, also started a home dialysis program because of the opportunity they saw to help patients in terms of rehabilitation, to be able to maybe even get back to work, and as well as the lowering of costs. And they recognized quite early on that actually the cost for sending patients home on hemodialysis was still roughly half the price for caring for patients in center. And what happened with all this was that they were clearly starting to recognize that there's other patients out there who need this therapy, and it's a costly therapy. And at the time, there was no federal funding for this. So they had to think about what are ways where we can provide more care, more high quality care specifically, to more people. And doing things this way by getting patients home allowed them to do that. And to such an extent that actually in 1967, they instituted a policy throughout the state of Washington that said all patients who were reaching end-stage renal disease, as it was referred to, should either should go straight to a kidney transplant if possible, or receive home-based dialysis. And they did this all very effectively. But as I mentioned, at the same point, they're also seeing the numbers are increasing, and they're running into some challenges which are actually ethical in nature. And some of you here might actually recognize this picture. It's a famous one that was placed on the front cover of Life magazine, where they had created a group to actually make decisions upon whether people would be candidates for dialysis or not. And if we actually look at the beginnings of dialysis in this country, it's also the beginnings and the underpinnings of bioethics in this country, and in medicine as well. So these were obviously really difficult conversations that had to be had. They put forward groups of people to help make these decisions, not necessarily stating that there was always the right decision, but the best that they could with the resources they had. Because I think, as everyone here knows, we were still several years premature until the federal government actually passed into law in 1973 the ability to afford and provide dialysis care to anybody in this country. So without leaving out peritoneal dialysis, I think it's important to certainly mention that, because that has really become the cornerstone of home-based therapy here in the United States and most parts of the world, much more so than home hemodialysis. Just a little history here is that actually the first patient to receive it here in the States was 1959, a patient named Richard Rubin. He actually worked, I believe, for Boeing, if I recall, and did so successfully for a period of 6 months to help manage his kidney failure until he ultimately died. And then it was about 5 years later when a physician named Bowen described two patients that were treated using an automated cycler. So here's the first beginnings of actually moving away from manual exchanges and actually using a cycler, but nevertheless still having to perform repeat punctures because they didn't have an adequate access at the time. And later reported, a 1 year experience. These patients, survived, or at what was then considered a significant amount of time. So it's a wonderful history. It's a fascinating history from my perspective. And yet I think, as probably most people here are thinking and realizing too, somewhere along the way, we kind of lost our focus, because home-based therapy really took a major dive, frankly, after this period of time. Here it is. It's successfully pioneered in these locations as I described to you. In places like the state of Washington, it's It's home or bust. You're gonna do home if you can't get a kidney transplant, and they did it very successfully. And at the time when the ESRD, Medicare ESRD program was initiated in 1973, we had 40% at least of the 10,000 patients treated with home hemodialysis. But then if you actually move ahead, a little over 25 years later, now you have what? You have over 250,000 people receiving dialysis care in the United States, and fewer than 2,000 who are actually on home hemodialysis. So what happened? As Christopher Blagg wrote in a really terrific editorial several years ago, or many years ago now, Dr. Blagg was actually one of the pioneers in Seattle who came there from training overseas and really was the nephrologist who was one of the, like I said, clearly lead people who brought home therapy to not just to the Washington state, but actually to this country. And as he described it well, and I think summarizes it well, there was clearly a proliferation of patients, right? As you made availability to the masses, those who needed it, thankfully, you also had more people to care for. And from that came the for-profit dialysis industry. And this is not to vilify that in any way, because at the same point, there were still cost factors involved. And the dialysis industry recognized that the most efficient way to help provide this back then was to start outpatient dialysis clinics where you'd have different shifts of patients coming. And as a result, home-based therapy started to decline. And with its decline, of course, became less education regarding it, less emphasis. And at the time, because if you could buy, you know, dare I say, from a scale perspective, be able to provide dialysis more efficiently, it was more cost effective at that time. So that's our history. That's where we're coming from, and this is where where we've started to evolve to. And now, if you actually move forward to present day data from the USRDS, you'll see here that as one thing that's a change is that in many places you'll see ESKD over ESRD, but from our perspective at the forum, anything through the federal government is still generally described as ESRD. But by the end of 2023, the total number of Americans living with end-stage kidney or end-stage renal disease had hit an all-time high of 830,000 people. Now, mind you, I do want to let everybody know that when we look at federal government data, when we talk about ESRD or ESKD, we're talking about not only patients on dialysis, but also those who have a kidney transplant, okay? So there's an absolute increase in the number of ESRD patients in this country, 831,000. About roughly a third of them are living with a kidney transplant. And yet the rate of patients who are reaching ESRD has declined over the same period of time. Okay. And how do we describe that? How do we come to understand this better? And I think certainly it's a population rise is one major factor. And I think it also speaks to some degree of success in terms of preventative measures and helping patients not reach ESRD. And yet as a total volume and total number of people here living in the United States, we have seen absolute numbers increase, which means more cost to our healthcare system. The other challenges that we face, of course, is that for a person living with end-stage renal disease, if we compare this to people who are diagnosed with cancer or other chronic conditions, such as maybe heart disease, if you take a look in the bottom right-hand side of the slide, you see that mortality rates are incredibly high for this group of patients. And it's costly from a mortality perspective as well as a morbidity perspective. And furthermore, when you actually talk about the affliction of kidney disease, we also see that it disproportionately affects people of color. And while we have recognized over the years that there's some component of genetics that may play a role to this here, and it certainly does actually with things like APOL1, at the same point, there's no question that socioeconomics factors and other things play a role too. And we need to continue to really work and strive to make sure that we're providing more equitable care to all people here in this country. So with that background and with the recognition that we have more patients to care for, what does this practically look like in terms of cost to our healthcare system? And if you take a look at the entire population of people who are Medicare beneficiaries, 1% of that group are people with end-stage renal disease. So if 1% of the Medicare population is ESRD patients, if I were to tell you that actually the cost of that is at the minimum 7%, now probably more 8 or 9% of the entire expenditures of Medicare, I think you can begin to appreciate the fact that it is incredibly costly to provide care to people who are suffering and struggling to live with ESRD. And in fact, if you break it down, this is data now, which is 5, 6 years old at least, but I can tell you that the numbers here have, at least the proportionality of it all has remained where it is. And if anything, it's gone up a little bit more, as you can imagine. You can see that providing hemodialysis to patients in terms of all costs for their care in a year, not just dialysis specific, but also the general health care and the hospitalizations and all the things associated with it. On average, we're talking about 90 and probably closer to $100,000 easily for care for every individual living with ESRD on dialysis, hemodialysis specifically. If you have those individuals receiving hemodialysis at home, the cost is about $7,500, maybe $10,000 less. And as you can see here, if they're on peritoneal dialysis, it's even substantially lower. And of course, at the end of the day, I think most, if not all, but most patients who are living on dialysis would very much love the opportunity to have a kidney transplant. And as you can see, it's really one of those things, as one of my partners here at the forum would say, is a win-win. It's for most individuals with end-stage kidney disease or end-stage renal disease, it gives it gives a better quality of life, and it's also more cost-effective for our healthcare system. So a lot of things to think about here in terms of how we provide the best care to our patients, and at the same point have a mindset that also thinks about society at large at the same, simultaneously, which is not an easy thing to do. And again, if you take a look at where we are in terms of trying to encourage more home therapy utilization, you can see that since 2010, even moving into to 2020, that there was an increase in home dialysis uptake from about 9% to closer to 14%. And I can tell you all, and I'll share with you in a little later, that those numbers have continued to increase. But by 2020, those increases were probably less related to more modern day value-based care exercises and more related to the prospective payment system and the changes that occurred in 2011 that did increase reimbursement for facilities that were offering peritoneal dialysis to patients. So this is kind of where we're at now in present day. And with that has come the question in terms of how do we provide better care for our individual patients and simultaneously provide also better service, better care to society at large. And how do we align those interests in a wise, thoughtful way? And one effort that's been created to try to achieve this has been something called the Advancing American Kidney Health Initiative. It was created in 2019. Its goals, as you can see here, were threefold. One, to reduce the risk or progression to kidney failure, with hoping to attain 25% reduction by 2030. Second goal was to improve access to and quality of patient-centered or person-centered treatment options, and really encouraging patients to the extent of actually getting 80% of people reaching ESRD to go either home or to transplant by 2025. As you all can imagine, and I'll cut to the chase, we haven't achieved that. These were aspirational goals, and I like aspirational goals, but nevertheless, we certainly have fallen well short of that goal. Goal 3 was to increase access to kidney transplants by doubling organ availability by 2030. Likewise, we're probably on a pace that's not going to meet that mark, but nevertheless, we're probably a little closer to goals 1 and 3 than we are to goal 2. But those are what it was set forward as challenges to the kidney community. And the way of trying to achieve that was actually creating different models of care that were created. I'm not going to go into great detail into the specifics of the different models, but I would like to say that first and foremost that there was kind of two general categories of kidney care models. The first one being a mandatory model for specific groups chosen throughout the country called the ESRD Treatment Choices Model that began in January of 2022 and then actually closed or finished this past December. And then in another group of models they refer to as 2 through 5, were voluntary models, ones that would kidney-based providers, which would mean physicians, and in some cases also kidney care entities that could include dialysis companies, could be involved either together or individually in terms of the kidney care choices model. And that broke down into a kidney care first model that was solely physician-led versus the comprehensive kidney care contracting model, or CKCC, that was involved with physicians as well as dialysis organizations. And that broke down into different levels of risk, which you can see here as kind of being brought down into professional, global, or graduated. And at the time of this conversation, the CKCC is the one set of, or the models that really continue to exist at this current time. The Kidney Care First model closed or finished at the end of December of this past year as well. And what did they accomplish? What did they do to date? Well, as a brief overhead kind of summary here, the mandatory model or ETC model did not actually find an increased uptake in home therapy or waitlisting or kidney transplantation compared to those that were not involved in the ETC model. Now, that's not to lay fault at those involved in the ETC model, but I think it's also a very interesting learning point, and one that's a whole separate talk on its own in terms of how do you lay out different types of performance models to encourage different behaviors and different ways of trying to provide more services and opportunities to our patients. The Kidney Care Choices model, the voluntary part of the KCC that also closed, has since, or Kidney Care First, excuse me, has closed, but in terms of the CKCC, that continues, as I mentioned. And if you look specifically at the CKCC groups, there was actually an increased uptake in home-based therapy. There also was increased utilization of vascular access and avoidance of catheters for patients who are initiating kidney replacement therapy, and in less, what is kind of referred to as crash starts, if you will, or suboptimal starts. Likewise, when it came to kidney transplantation, they also saw an increase in terms of patients for the rate of kidney transplantation. So because the CKCC model had much larger volume of patients in it, and because of these early successes, this continues now into what I believe will be 2027 to see how this continues to play out. And with that said, while the goals were set forth for participants in these models, how you got there was not really specifically outlined. And that's what I kind of thought the second part of this talk really should kind of focus on, in terms of whether we're involved in value-based care models specifically, or working in our day-to-day lives as nephrologists and people caring for patients with kidney disease. I think it's critically important for us to kind of think about, how do we make sure that we really provide more choice to our patients and do so in an educated way? And I think in order to do that, we not only need to educate our fellows and trainees better, but we have to educate ourselves more as well. So, as you can see, probably a lot of it from the benefits of some value-based care, as well as other just general behaviors in the nephrology community, we continue to see an uptick in the use of home-based therapy, which at this current time and most recent USRDS data reports would indicate that roughly 15% of new and established patients are now receiving peritoneal or home hemodialysis in the United States. So we're achieving some successes. We're not achieving them at the pace and the rate that we were hoping for and the federal government was hoping for, but nevertheless, we are making some positive momentum. But how do we maintain that? How do we keep that going when we particularly recognize the fact that home therapy is tough, right? It's a therapy that many of our patients and loved ones who do it would really fight you in terms of trying to put them back in center again because they love the autonomy, they love many of the benefits to home-based therapy, and yet we also know all too well that many times patients are sometimes forced back in center. Sometimes it's like I said, it doesn't have to be. It's not their choice. They lose modality opportunities from access problems. With PD, for instance, sometimes they lose caregivers, right? And they have inability now to provide that care themselves. So we do come to home-based therapy recognizing that not only is it a challenge to better educate our patients and their loved ones about what home-based therapy is, but it's also a challenge that once we get them there to actually help keep them there. And so we do have attrition that we have to battle with every year as well. And, I think with that has come many, many bright, intelligent people who have come together to say, what are things that we can do to actually help provide more opportunity to our patients? And one area of opportunity and one thing I think that's I refer this group to kind of look at a little more closely was KDIGO had gotten together in 2023 and published a consensus of their different thoughts about what they thought could actually make home dialysis more available, as well as also identifying things that we could do to actually and try to identify as issues that we need to try to address to make ourselves more successful, not just nationally, but internationally as well. And if you take a look at these different consensus points, primarily in the top part here, you'll see different comments about all patients in need of maintenance dialysis should obviously have this option of home-based therapy. That we need to look at things from economics and local policies and make sure that it's adequate and fair distribution nationally and other places, and looking at clinical outcomes and really doing more research in that area. But the one thing that I kind of would point this group to, as you can read through the different points here, is the topic of high quality education and clinical experience by healthcare professionals. How are we teaching not only our trainees, but our colleagues, some of whom have been practicing nephrology for 3 years or 30 years? And what do we do to really help make sure that everybody in the nephrology community is up to speed and able to speak to their patients about this thoughtfully in a way that our patients and their loved ones can understand, and also in a way too that our trainees can understand as well as they're adopting and learning some of these best practices. And at the end of the day, I think we still have to obviously keep that focus on the fact that it needs to be all about the patient, right? Everything we do here needs to always maintain the focus on our patients and what's best for them. And while many people out there would love to see and say, well, home first, I also recognize that there are some who say, no, thank you. That's not for me. And as long as any patient has received the best education possible and can make that type of informed decision, I think obviously that's absolutely an equally viable option to go in center if that's what a patient wants. But nevertheless, I think given the many different opportunities that are available out there, I do think there's many, many people who need this opportunity that just aren't getting it. And it really starts with us. If we're gonna make sure that we give people these opportunities, we've got to be able to speak to it better. So, how do we do that? Well, we have to look at where are our shortcomings, where have we failed, or where are we not really meeting the need in terms of providing the best education possible within the nephrology community. And I would point people to first and foremost to this study that was published several years ago now, that was actually a self-reported questionnaire to fellows in the United States, asking them, what's been your experience with home dialysis? How confident are you to manage different problems? Do you feel prepared now that you're getting ready to graduate, to manage home hemodialysis or peritoneal dialysis? And if you take a look here from Miller and colleagues, you can see a lot of interesting data to be garnered from this. First of all, if you take a look to the left-hand side of the screen, you'll see that for many fellows in their training programs, upwards a little over 40% didn't actually have dedicated continuity clinics for home therapy. And take a look in terms of, of those that did, how many of those home dialysis therapies were to any degree of, substantial numbers to actually be exposed to volume. Again, you can certainly see some worrisome numbers here as well. And as well as the fact that many fellows maybe were exposed to peritoneal dialysis, but not to home hemo. And if we take a look in the table 2, the question of, are you comfortable in terms of managing fairly common problems that can arise in peritoneal dialysis or home hemodialysis, even writing the prescription? Again, there's a lot of work to be done, as you can see, in terms of trying to really improve the training of our fellows. And again, to the right-hand side, just overall confidence is clearly lacking for many of our fellows who are graduating. So, I'd like to believe that over the last, 5 to 6 years since this data was published, that we've improved some, but I think we also know too that we're not at 100%, and we really can't settle for anything less than that. So what do we do about that? And I think there's been a lot of, or fair amount at least, written about the different opportunities, different things to offer, and many groups that are actually putting their money and their time where their mouth is, and really standing behind that, as I'll show you. But clearly, I think first and foremost, in our general nephrology fellowship programs, we obviously need to ramp up the exposure and the experience for our fellows. And we can do that in a lot of different ways, right? We can offer structured clinical exams, objective ones, OSCEs that I've offered in my fellowship program. We can look at externally at different places, such as and I'm not here to support or stand behind anyone in particular, but such things as Home Dialysis University, Project Echo is another one that was brought up in the past, and different educational options, dedicated months in addition to having continuity clinics. So there are many different options here. And in the midst of all this too, as many of you probably know, there has also more recently been a few programs starting to stand up an extra year of home dialysis dedicated nephrology training beyond general nephrology, which I think is a wonderful opportunity. Again, needs to be funding for it, but I think we need more people with expertise out there with home therapy. The University of Alabama is a group that I will happily say stands out for really doing some wonderful work with home therapy training. They offer a training program themselves, as I mentioned, and they've looked at things from many different efforts and approaches in the training perspective, right? That there's clearly an issue of education that needs to be approached, but also too we need to improve ways for literally for access, physical access for our patients, and dialysis access for our patients, and develop those types of relationships with access providers. Clearly more multidisciplinary teamwork and other innovations. And if you take a look here, they have online a curriculum that they offer that if people or anyone out there who's involved with training of fellows, I really encourage you to take a look at, and where they even break it down into setting objectives for the first year and second year of training and structuring it in different ways. So a lot of great opportunities. But as I said earlier, it's not enough to train our fellows if we ourselves are not really fully educated and aware and are really comfortable with teaching home therapy. And that's really a place where I believe that while the forum's creation of different educational endeavors, including the home dialysis toolkit, as you see here, is absolutely meant for fellows as well. It really does have a focus in people who are fellowship trained, because as many of you here know and have seen in our previous talks, that we do talk a lot and provide a lot of education and support for leadership, whether it be through medical directorship, managing emergencies, and how to really build programs. And that's something that in this home dialysis toolkit that we initially published in 2016 and then updated just a couple of years ago, our goal was to really make sure that we not only can help provide structure for running a home therapy program, but actually be able to help troubleshoot and address ways of really leading these programs. Because once you know how to do that, I think we're really making the ideal personnel, the people to be really training our fellows as well. And if you take a look at the toolkit and what it provides, and like all of our other toolkits, just like these talks, they're all free to the public. And I encourage people just to go to our website and take a look anytime you wish. Our more updated one has actually provided a bit more additives in terms of the patient voice, which I'm very proud to include. I think if we don't understand from a patient perspective what really they need, we're not going to do the best training possible for our fellows and others, right? So there are some great videos that are available from our Kidney Patient Advisory Council members addressing specific areas in our toolkit. And we've also updated it to make sure that there's discussions about the Advancing American Kidney Health Initiative that we've talked about earlier today, the conditions for coverage and how those pertain to a home therapy unit, emergency management specific to the home therapy unit, and then talking about as we're talking about today, advanced alternative payment models and value-based care and other things that you can see here. So, and just to kind of delve in a little more specifically for a moment, I just want to show the group that we as part of my ask when I was chairing this update was of our patient partners in this endeavor to say I really would love to hear from you all in terms of give me a top 10 list. Tell us what are the things that really worry you and concern you the most, and that you feel that nephrologists like myself or our trainees need to be aware of. To make sure that we're really providing you the best care possible. So they put together a call to action that we've published in our toolkit. And I really would encourage everyone to go through this in detail to better understand really what is important to many of our patients who have lived through and worked on all different modalities of dialysis throughout their lifetimes. We also have topics regarding overcoming different barriers when it comes to educating clinicians and medical directors, as well as a chapter on addressing staffing considerations. How do you manage your staff? How do you work with those? How do you make sure that they have the appropriate education? How do you deal with overnight coverage and support? And those are all things which I think are maybe assumed or taken for granted a lot of times, but things that really need to be discussed. And this toolkit includes that. As any of you here today hopefully had a chance to listen to Dr. Maloney's talk yesterday, there's nobody better and more capable of really talking about emergency management in the dialysis world, I would say, than Don. And he actually, sure enough, helped and participated with this chapter of emergency management in ways of really kind of helping to make sure that we educate not only our staff, but our patients about being prepared. And if you think about it from a home therapy environment perspective, it is a different animal, right? Patients need to be prepared for manual exchanges or how to do without dialysis for certain periods of time. And this chapter actually goes through that in detail for a home therapy patient. And we also had a really wonderful opportunity to meet with a provider or some providers out in the Southwest United States who are working in a very rural environment and trying to really make a home therapy program succeed. And how that looks compared to someone working in an inner city can be very different, as you could imagine. And so we actually included in our toolkit just a really a wonderful, not only a story, but actually a description of how they succeeded in terms of providing care to patients, many of whom lived, close to 100 miles away from a home therapy unit. And how do they actually make that work? And while, I can speak from my own perspective that many of our patients here, we're more of an inner city environment for the most part where I am in this part of Massachusetts. And yet at the same point, we've also recognized that there are many times where we have patients, whether because of tracheostomies or different things, where the therapy needs to occur, the training needs to occur at home, not in the center. And so we have to adapt and learn how to manage those things. And then one of the last things I just wanted to share from the toolkit was that we also address different things like how to stand up a transitional dialysis unit. What about those patients who come in to in-center dialysis, hemodialysis, but really didn't get a chance to receive that education to know what home therapy is and give them the best opportunity possible to make sure that they understand all of their options once they've reached ESRD. as well as self-care units, which has something that has been utilized in different parts of this country. I know Philadelphia is one of them that comes to mind, where for patients who maybe don't have the support that they need to truly be home, but it's an opportunity to provide patients the ability to have some autonomy in their own care when they're in center. It might be managing the machine themselves. It might have to do with them even cannulating themselves. But it's a way of, like I said, when we give patients more autonomy, I think they tend to really have the opportunity to succeed more in every sense. So, we've certainly talked about urgent start processes that we discussed in our toolkit, and you've all, I'm sure, heard it in other places. That's certainly something that we really need to be thoughtful of and make sure that our trainees are aware of. And as I mentioned earlier, we also have to really think long and hard about how do we create relationships with whether it be vascular access surgeons or interventional nephrologists, and look at ways where we can make sure that our patients receive the timely care that they deserve, right? It's a real challenge when we think about peritoneal or vascular access for our dialysis population, particularly knowing that there's such an urgency when they need the care. These are not patients who can wait a week. They need to get things done in a timely manner. So there's a lot of work to be done there, but we need to kind of build on those relationships and in different ways to do that. And with that said, I just wanted to kind of tie things up a little bit here today with some of my own group's personal experience. I am a private practitioner, actually, even though I've been involved with and run a training program for fellowship over the years, and as well as leading different ventures. But my group, my members, my partners, and I have been involved in some of the early parts of value-based care, referred to as the ESCO or ESRD seamless care models, and then gone on to the more recent voluntary models that I talked to you about today. Our current dialysis population right now, we have about 18% prevalence of home therapy, which is pretty good, a little ahead of the national average. One thing that kind of stands out a bit, makes us a bit more atypical, if you will, is that if taking a look at our home hemo population, we're actually more 2-to-1 home hemo to PD. Very, very different than what you see in most parts of the country. And if you took a look at our prevalent patients back in 2010, we were less than 10%. So, we did it, and anyone else out there can as well. The different things we've done over time is, I think we've taken any successes we've had from these different value-based payment models, and we've reinvested them into structure. If you don't do those things, you're not going to succeed long term. And I think that's one of the challenges to some of these value-based payment models, is that we really need to have a mindset to say success is not just in the short term, and it's not a financial one. It's one where we, secondarily, hopefully can save money for society. But first and foremost, we need to maintain and frankly improve quality for our patients. In order to do that, we need to reinvest that type of stuff into things like education in our office, so that patients are receiving more intense education prior to reaching dialysis, and hopefully never reaching dialysis. Opportunities for transitional care units or TCU experiences are a great one too for some, maybe not all. But I think if you also can really maximize what's going on in your office, maybe you can actually do things without a transitional care unit. Vascular access and transplant support are critical, certainly too. And also one of the things that we identified personally was availability for peritoneal dialysis in different rehab settings. And it wasn't until just recently that we even had opportunities for our patients on PD, if they were hospitalized, to make sure that they could safely continue in their modality in rehab and not have to forcefully convert them to hemo, which unfortunately happened many times over the years. So, we've had success in different areas like optimal start, as well as different patient engagement interventions. And just to kind of, for the sake of time, tie things up a bit, I will share that, through different activities, in our office, and I encourage people to do it in theirs as well. Nurse-driven things are frankly the most successful ones I tend to see. And I know my partners would agree with me on that as well. And this is just one example of interventions that we've done over the years to increase kidney transplant evaluations in the office, and things that we can actually do to help. If you can do it here, you can do it with home therapy as well. And likewise, we've actually done that in terms of improving home therapy choice by actually using such things as transitional care units as well as education in our office and different approaches. My hope in the future is that we will receive more governmental support in things like home assisted dialysis. And that's something that has been introduced as a concept at the federal government level, but unfortunately, at this point in time, still languishes out there and is not quite ready for prime time yet, but does have many proponents who are supporting it. But as I think all know right now, it's also a time where we need more financing in order to do that. So, but it does work off of the fact that it's been successful in other parts of the world, and as well as it's also been structured and built for instance, here in the United States. I know out in the Los Angeles area, Dr. Schiller and others have done assisted PD and reported on this and with great success. So we know it's beyond just a concept. We know that it's really something that actually works and can support our patients. But we need that financial support to really make this happen. And so some of the things I've talked to you about today really are things that we maybe don't need so much the finances, but we just need the work and the effort and the training to really build on. But other things we do clearly. So in summary, I've at least can say I've taken a lot of lessons learned from my experience in value-based care over time, as well as work in the home-based arena, where I've been a medical director now for many years. We clearly need better training for our next generation of nephrologists. We clearly need creativity for home support. And it could be such things as, urgent start PD, and maybe hopefully assisted PD in the future for patients who don't have loved ones who can help them at home and yet allow them to still succeed and stay there. And certainly we really need to build on the cornerstone or foundational thing, in my opinion, of really better patient and family education in the dialysis clinic, long before patients reach end-stage kidney disease, right? How many of these patients, are not getting an opportunity, never mind for a home therapy option, but even getting an opportunity to meet with it at a transplant center. And that's a shame that we can no longer accept. So we have to make sure we're really making changes there. We certainly need to improve transitions of care. One thing I've learned very much about value-based care is that the transitions of care and preventable hospital admissions or readmissions or different things are unfortunately great ways to lose modality for home therapy patients. It's incredible cost to society, and obviously it's a major burden on our patients. So there's definitely things we can work on there. One thing I can't say enough is that our in my group are the benefits we've gained from hiring and working with advanced practice providers has been found really foundational to us, and something I encourage people to really think about and to do things in really creative ways. And again, I think the last word I'll say as I close up here is what I kind of have outlined all along, that it's not enough to say that we're going to try to improve the training for our fellows. We have to make sure that as nephrology providers and providers of kidney care and at any level, we need to be better educated ourselves. So I think it begins with us and it needs to end with us, and we need to make this better. And that's how we're going to really accomplish these other things as well. So I want to thank everyone here today for listening and for your time. I am going to share just a couple last slides of just a reminder to everybody that there will be a survey link coming to everybody who joined today, and really just encourage your honest feedback. It makes us better, and we're not afraid of it. So this is our first year of this program, and we hope to have many more of it, and we hope you've enjoyed it. And again, just a reminder that the forum is completely a voluntary organization. The time that's put into these, not only these talks, but also to our toolkits and other things you can imagine is significant. And any kind, thoughtful donations are certainly welcome, but not, but recognized as not for everybody, but still, we very much encourage any small donation is absolutely welcome. And reminder that everything it remains free on our website, and this is where you can find us on different social media platforms. Okay, so thank you again for this opportunity, and I will turn off the slides.
Thank you, Dan. That was wonderful, and you raised a lot of thought-provoking questions and things we, have debated for a long time, especially staff-assisted dialysis, and these are things that are being done in other countries, but we are still kind of behind the curve. And also the nursing home situation, we face the same issue here. It just doesn't make sense to transition a patient from a home modality to, in-center, especially when they're trying to recuperate from, any kind of a stressful situation or surgery or whatever. So things have to change. Andy, I see your hand up.
Yeah, Preeti, Dan, terrific job. I just wanted to share something with you in the group, and I apologize if everyone already knows about this. I just thought this was so pertinent. There's a congressional act which either was just introduced or will be. It's called the Kidney Disease Education Access Expansion Act of 2026. Supposed to be introduced by Congressman John Joyce and Congresswoman Suzanne Delbene. And this something you know well, Dan, as I do, and others who've been involved in value-based care. But a lot of the opportunities we had for KDE education for kidney disease that we were given waivers for, this would expand to all providers and really allow actually not just stage 4, but dipping back even into stage 3 and would make it possible for many healthcare professionals to give this. I just wanted to put that on the radar. I thought it was so pertinent to add to everything you just told us about.
Thanks, Andy. Like I said, I know the first generations of this, I think, came around 2021. They really did kind of languish out there for a while. It's great to hear that things are hopefully starting to move forward where we can actually get some momentum on this.
Any other questions from the participants, the audience?
Yeah, I see a comment from Dr. Maloney about maybe developing a curriculum based on this presentation. Yeah, I think there are lots of opportunity, Don. I agree. And, I said when you look no further than I've had one of my, like I said, I'm quite proud of the fact that I think we've built a good solid home therapy program through my group, but we still have a long ways to go. And I wasn't hesitant for a moment when one of my fellows, when we identified that the University of Alabama had a educational program that we sent her to. And I said, why not, get information from different people and really get a chance to see what you already know and see what else you can learn. And it's those types of things that I think we need to really build on. And I think there's some great opportunity here. I agree.
1 hour doesn't do justice to this topic. You did a great job. It's very interesting. I learned a lot. But there's so many things to really explore even further. And that's why I think developing this into a curriculum in collaboration with the University of Alabama or other stakeholders in this area would be really exciting.
Yeah, I agree. Thank you.
Yeah, it's a great point, Don. Thank you. Okay. All right, I think we have a couple of minutes to go, but if there are no other questions, I think we can close the webinar and thank you all for joining. And again, we have the last webinar coming up on June 23rd. Dr. Deborah Hain will talk about effective rounding in the dialysis unit. So hopefully you can all join us. Thank you all.
Thanks, everyone.
Bye.
Take care.